Hello everyone. In this video, we will discuss clinical cases in ECG and we will be covering P-wave abnormalities and QRS complex. So this video is mainly ki how to go for analysis of the ECG. Uh, we should go for clinical information first. We should make our differential diagnosis, then look at the ECG. So starting with the first clinical scenario, 60-year-old male with history of smoking presented with cough, chronic dyspnea and swelling of the feet. So looking at this information, our first differential diagnosis will be ki COPD. Patient is having COPD. So on examination, there is barrel shaped chest. So further supporting our diagnosis, bilateral rhonchi are present in the chest, airway obstruction is there. JVP is raised and patient has S3 which increases on the inspiratory phase on left lower parasternal area. So that means this S3 is right ventricle S3 because it increases on the inspiratory phase and it is over the tricuspid area, that is a right ventricle area, which is also known as the on the left lower parasternal zone. So, patient has a COPD, swelling of the feet. That means ki there is some sort of a right-sided heart disease which is developing. So, let's see how it will affect the heart. It will affect the right ventricle. It will affect the right atria. So, it causes a right atrial enlargement. So, once it is clear in our mind ki what will be the expected finding, then we look at the ECG. So, in the ECG, if we are suspecting a right atrial enlargement, then we will look at the lead 2. So in the lead 2, because we are suspecting right atrial enlargement, so focus on the P wave. So this is a P wave. Normal P wave height is less than 2.5 mm and that is due to right atrial activity. So if the right atria is enlarged, there will be an increased height of the P wave in lead 2 and that height, if it is more than 2.5, is known as P pulmonale. So P pulmonale finding is present. You can look at this ECG. One wig square height is 5 mm and here the height is 4 mm, just less than the one wig square. So it is a case of a P pulmonale. Also, if you can see the axis, QRS axis here in the lead one, QRS is negative, predominantly negative, and in AVF QRS is positive. So if this is happening, it is a right axis deviation. So which is obvious because it is a right sided pathology of the heart. Come to the next clinical scenario. 22-year-old female presented with dyspnea and swelling of the feet. Past history, there is a history of migratory joint pains and patient is taking beta blocker for previous episode of atrial fibrillation. So migratory joint pains means patient has rheumatic heart disease most likely, and that must have caused some sort of valvular heart disease. So let's see which valvular heart disease it will be. Loud S1 is there. So valvular heart disease, only two valvular heart disease cause loud S1, tricuspid stenosis and mitral stenosis. Opening snap again caused by MS and TS. So murmur will differentiate the location of the murmur and whether it increase on inspiration or expiration will decide whether it is a mitral stenosis or tricuspid stenosis. Tricuspid stenosis will increase on inspiration and it will be on the left lower parasternal zone, and mitral stenosis will increase on expiratory phase and it will be heard at the cardiac apex. So mid diastolic murmur is present at the apex. It is a case of mitral stenosis. So mitral stenosis, the first chamber to get affected is the left atria. It causes left atrial enlargement. So our expectation will be left atria will be large. In lead to width is due to left atrial activity, so it will increase, and in V1 the negative component of P wave is due to left atria, so it will be increased in area. So let's look at this ECG. So in the lead 2, this is a P wave, so you can see the P wave. Normal width of the P wave is 2 or 2.5 maximum. So here the width of the P wave, as you can see, is 4 millimeter. So it is increased. This is known as P mitral. Also, there is bifid P wave which is very prominent, known as camel hump. So this sign is a specific sign of left atrial enlargement, camel hump sign. And width increase more than 2.5 is known as P mitral. While in a lead V1, So when we look at the negative component of the P wave, and we will multiply the depth with width. So if it is coming to be more than 0.04 mm per second, this is known as Morris index positive. Now, the next case, 30-year-old male, sudden onset of palpitation, and after vomiting, which is self-induced, there is a sudden cessation of palpitation followed by polyuria. So sudden onset of palpitation with sudden cessation is highly suggestive of PSVT, paroxysmal supraventricular tachycardia. And after the tachycardia is over, there is some sort of atrial stretching. And due to atrial stretching, atrial natriuretic peptide is released, and that causes polyuria. So typical history will be given by the patient. There is no history of structural heart disease. Now patient got the ECG done during the palpitation episode. On examination, Canon A wave in the JVP is seen. Canon A wave will occur when atria and ventricle depolarize at the same time. So there are few causes for that, and that lead to the Canon A wave. So in PSVT, atria and ventricle, they contract almost simultaneously, and the rate is more than 100. So this is tachycardia. Pulse rate is 180 per minute and regular. PSVT is a regular rhythm. So this is in our mind ki we are dealing with the case of PSVT. So how does the ECG look like, and what is the P wave abnormality there? So when ventricle and atria are depolarizing at the same time, so QRS is a larger complex that will hide a smaller P wave. So when two electrical activity are taking place simultaneously, large electrical activity will hide a smaller electrical activity. So in this ECG, there is no P wave which is present, and heart rate is very fast. Now you will ask, what is this wave then? So this wave is a T wave. P wave is hidden. But how will you say that this is a T wave? Reason is, whenever between two QRS complex, you find only one wave of same morphology, consider that wave as the T wave. So this is a T wave. P is absent. This is the abnormality of P wave. Now, next one. Patient is a known case of chronic kidney disease, missed two dialysis sessions, now presented with uneasiness. So, when patient misses the dialysis sessions, urea will increase, creatinine will increase, potassium will increase. So, potassium will cause ECG changes in the form of P wave will be absent. For that, you can watch our video of hyperkalemia and ECG changes. So, this is the ECG you can see. This is a QRS complex which is wide. This is a tall T wave, and before the QRS there is no P wave. So P wave is uniformly absent here. That is the effect of hyperkalemia. Next clinical scenario, patient has hyperthyroidism presented with palpitations. So there are two causes of palpitations in a patient with hyperthyroidism. One is most common cause sinus tachycardia due to sympathetic overactivity, and second is atrial fibrillation. So sinus tachycardia will have a regular rate, regular heart rate. Atrial fibrillation will have irregular heart rate. Now on examination, A wave is absent, so that is absent in atrial fibrillation. Sinus tachycardia will not cause a loss of A wave in the GVP. So this A wave is absent due to ineffective atrial contraction in AF. Pulse rate will be 120, and that is irregular given. So again, supporting the diagnosis of atrial fibrillation. Pulse deficit is 12. Pulse deficit is heart rate minus pulse rate. So if it is more than 10, it is highly suggestive of atrial fibrillation. So what will be the ECG of atrial fibrillation? Ineffective atrial depolarization will make P wave absent. Heart rate will be irregular. So here is the rhythm like in between the two QRS complex, you can see these are the T waves. These are T wave of same morphology, and no definitive P wave you are able to make out here. And when you see the RR interval, they are highly irregular. So this is a case of atrial fibrillation with absent P waves. Another case, 50-year-old male has MI involving the right coronary artery. On examination, Canon A waves are seen with a rate of 50 per minute. So JVP Canon A wave when atria and ventricle depolarize at the same time. So when will this happen? This will happen. Look at the history. Right coronary artery supply SA node. So if SA node arrest occur, AV node will become the pacemaker. If AV node is the pacemaker, so above is the atria, below is the ventricle. So the impulse will go to the atria and ventricle at the same time. So atria ventricle depolarize at the same time, and rate of AV node depolarization is 40 to 60 per minute. That is known as junctional rhythm. So here the junctional rhythm will be there, canon A wave 50 per minute. So P wave will be absent. Atrioventricle simultaneous depolarization, QRS will hide the smaller P wave. So this is the absence of P wave. You can see just before the QRS there is a flat line, there is no P wave. This is a T wave. We look at the arrow, this is the T wave. Why? Because between two QRS complex there is only one wave of same morphology, and that will be T wave. Now coming to the QRS abnormalities. QRS abnormalities can be like right bundle branch block, left bundle branch block, right ventricle hypertrophy signs, or left ventricle hypertrophy signs. So 60-year-old male with a history of uncontrolled hypertension. Whenever uncontrolled hypertension means systemic hypertension is there. So BP is 160 by 100. So directly left ventricle will be affected in the form of pressure overload. That means LVH. So we will be expecting LVH signs in this condition. And there is LVS4. So that confirm that left ventricle is stiff due to LVH. So we will look for the signs of the LVH in the ECG. So the signs of LVH in the ECG is if we will add S wave of V1 plus R wave of either V5 or V6, and the sum is more than 35 mm, it is LVH. And individual height of R wave in V5 or R wave in V6 more than 25 mm, then it is also LVH criteria. So here you can see the depth of the S wave in V1, 5, 10, 15, 20. 20 mm is the depth, and the height of the R wave, we will take the R wave height from the baseline. So this is 5, 10, 15, 20, 25, 26. So if it is 26, this is 20, so 46. So it is a voltage criteria for LVH. Indeed, individual criteria of the R wave is also satisfied here. The height is 26 mm, so it is LVH. Also, what you can see in this ECG, LVH causes a left ventricle predominance, so it will cause left axis deviation. So lead 1 QRS is positive and AVF QRS is negative. So these QRS are going away from each other. So this is a left axis deviation. To understand the axis deviations, you can watch our video on QRS axis. Now, another case, 35-year-old female with primary pulmonary hypertension presented with progressive dyspnea for the 6 months. So it is already a diagnosis of primary pulmonary hypertension that affect the right ventricle in the form of right ventricle hypertrophy. So on examination, lungs are clear because pulmonary hypertension, primary pulmonary hypertension will not cause any crepitations or rhonchi. JVP is raised, that is most likely due to RVH, pressure will be transmitted to right atria and JVP will be raised. S4 is heard at the left lower parasternal area, that is a right ventricle area. It increases on inspiration because it is a right-sided event. So our expectation will be RVH signs, and RVH sign we will see in V1 because V1 is near the right ventricle. So the height of the R wave will be more than equal to 7 mm in right ventricle hypertrophy. So if we look here, this is V1 and this is the R wave of V1. So the height of the R wave is almost 12 millimeter. So that is satisfying the criteria of RVH. Right ventricle is more prominent. It causes right axis deviation. So you can confirm whether there is a right axis deviation. Lead 1 QRS is negative and AVF QRS is positive. So they are going towards each other. So it is a right axis deviation. Next clinical scenario, asymptomatic 30-year-old male comes for a routine health checkup. That means patient does not have any symptoms of dyspnea, chest pain, palpitations. Now on examination, patient has a wide variable split of S2. So we will understand the causes of wide variable S2. So all of us know physiologically A2 come first followed by P2. So the width will increase if A2 is early or P2 is late. So there will be two causes. Wide variable S2 split, early A2, it is seen in mitral regurgitation or VSD, but patient does not have any murmurs clinically. Late P2 will be PS, will cause a murmur. Right ventricle failure will be symptomatic, and right bundle branch block. So out of this, right bundle branch block is a more likely possibility because it can be asymptomatic, it can be congenital, and it is characterized by RS R dash in V1 or V2 ECG leads. So let's see here V1, focus on the V1. So small r, S wave and capital R dash. So this is a typical R, S, R dash pattern, and here V2, R, S, R dash pattern will be there, and wide QRS will also be there. So it is typically a right bundle branch block. 65-year-old male with history of anterolateral wall MI come for a routine checkup. Now patient had past history, patient is asymptomatic presently. So whenever routine health checkup means asymptomatic patient. So there is a reverse split of S2. Reverse split of S2 means ki A2 is coming later than P2. No murmurs are seen, lungs are clear, so there is no heart failure as such. So the reason for the reverse S2 split will be mainly late A2, and late A2 will be because of aortic stenosis where there will be a murmur. Left ventricle failure where there will be a crepitation in the chest or patient has other LV S3 findings or symptomatic patient. Left bundle branch block can be asymptomatic after myocardial infarction. So for left ventricle, left bundle branch block, we will look at the V5 or V6. It will show a wide QRS, absence of initial Q waves, and M pattern or R dash pattern in the ECG. So let's see, focus here. So this is V6. You can see initial normal Q wave is absent here, and QRS complex is wide. It is almost 4 mm. Normally is less than 3 mm. And there is a slurring of the QRS complex, not a typical M pattern, but you can make it out that there is a slurring of the QRS complex here. This is typical of the left bundle branch block. So these were the clinical cases and their analysis in terms of ECG, covering the P wave and QRS complex. If you have any doubts or queries, you can put in the comment section. Thank you.